Welcome everyone to the Leukemia and Lymphoma Society of Canada's training called Physical Activity in Pediatric Oncology during treatment, the benefits, application, and tips. This training is geared towards the healthcare professionals in our communities. Let me introduce myself. My name is Alexandra Clark, and I am one of the Community Services Managers in Ontario for the Leukemia and Lymphoma Society of Canada. Before we begin our main presentation, I would like to share with you our mission and highlight some resources that may be helpful for you or someone you may know. At the LLSC, our mission is to cure blood cancers and improve the quality of life of individuals touched by blood cancers as well as their families. Ultimately, we are here to serve the community. We offer guidance and support to people affected by a blood cancer every step of the way. We offer a variety of educational resources and services for those affected by blood cancers, as well as for our healthcare professionals. In addition to disease information booklets, fact sheets, and videos, we also offer valuable resources such as a peer support program, virtual support groups, and a multitude of educational webcasts and podcasts. Last year, we launched the Your Life After Cancer program and recently added new services and resources for adolescents and young adults. We invite you and those affected by blood cancers to visit bloodcancers.ca for more information. So what can we do for you as healthcare professionals in our communities? First, we offer free tear pads to help facilitate patient referrals to the LLSC and to our services. You can order your very own tear pad by calling toll-free or emailing at info@bloodcancers.ca. Moreover, we are growing our continuing education program. This program is aimed at health professionals like you and provides access to training in a self-study format. You can watch them whenever you would like at a time that is convenient to your schedule. To know more about these training webcasts, visit www.bloodcancercontinuingeducation.ca to learn more. We will continue to add new material to the roster. For example, in October 2021, survivorship training will be available for healthcare professionals in French and English. Stay tuned for more details. It is now a time to introduce our speaker, Gabrielle Duhamel. Gabrielle is a kinesiologist and a PhD candidate in physical activity sciences. Over to you, Gabrielle.
Thank you, Alexandra. So thank you everyone also for joining this training session. This is a subject that is very close and dear to my heart, so I'll be happy to present it to you today. First, I'll talk a little bit about my who I am and what led me to presenting this training for you today, and we'll look a little bit about who are the children that are dealing with cancer. What is this population? We'll look at the effect of physical activity with pediatric oncology patients. So what are the effects of treatment, the benefits of being physically active, the ratio of risk benefits, some safety aspect, and also how to implement physical activity during and after treatment. Then we'll see some case study in different settings within the hospital, and we'll look into some multidisciplinary approaches and how the nurses can also support physical activity during the whole path of the treatment and after treatments. So a little bit about who I am. I've always been into physical activity as a young girl, and I did some speed kayaking and dragon boating in international competitions. And then I went straight into working as a personal trainer. First, I worked at the Women's Alaska Club in Anchorage, Alaska. Then when I came back to Quebec, I worked and got a certificate in personal training at the YMCA du Parc. And in 2001, I found out that my mom had breast cancer. And I really saw how the treatment and the surgery that she had to endure affect her functionality or capacities, and I really wanted to see how physical activity could help her. And I asked my supervisor at the YMCA how that could be done, what would he recommend, and basically what he told me is that this is a special population that needs to be basically supervised by bachelor degree tenant kinesiologist. Sorry, my English is not perfect, but I'll try my best. So that basically that I needed a bachelor's degree to work with this population. So this is what I did. And then unfortunately in 2004, they didn't have much information about cancer and physical activity. So I went more towards working with the patient in rehabilitation for chronic pain. And I worked with a population that were severely affected, that had been on the disability leave for more than 2 years. And they had a lot of somatization and psychosocial components to their files. And I really had to learn with the physiotherapist at the Nosy Clinic how to work in multidisciplinary settings, but also how to work outside of the box for those patients. So not just look at what were their injuries, but really what were all the components of the patient. I also work at the same time in a birthing house as an assistant midwife. So as I was working in the birthing house, it really got me to think about maybe going back to working in kinesiology with oncology patients, but this time with the younger population. So really how I could help them regain strength and help them within their process of getting back to health. And I started looking, and I found a program, a certificate, a postgraduate certificate at UCAM University that was in adapted physical activity. And they had a 300-hour internship program there where I could find, somewhere where I could find a good training and learn on the field exactly how to be with the younger oncology patients, mainly because in Canada there was no program and there's no services that exist for this population within the hospital at this time. So I knew that I'd have to go outside. But I was faithful that I would find something good. And then the same day that I went to deposit my registration, I also got myself a diagnosis of chronic myeloid leukemia. So I couldn't start the same year my certificate, but then I reapplied the following year and I was good to go. I was able to start and finish the certificate. As I was in this training, the professors at the university helped me find an internship at a pediatric oncology, at a pediatric hospital that had a department of oncology that offered physical activity within the hospital for the children for at least the last 10 years. And this is actually quite common, or more common in Europe, where they have many countries there where they have different hospitals that are pediatric hospitals, or that have departments that offer those services for the last decades at least. So I got my training there, I learned a lot, and then I came back, I was really motivated, and I was like, this is what I want to do in life, but it doesn't exist. So how to start this? So I really decided to do another certificate, but now into launching a business. So how to do a business plan, and I did all that. And then I was lucky enough to be put in contact with a researcher group at Saint-Justine. So I went ahead, presented my project of implementing physical activity at Saint-Justine for the children in oncology. And then they told me basically that they were not ready to offer the service yet, that they were at the step of testing the feasibility of implementing it within the hospital. And they said, either we can hire you as an expert, or you can do a PhD with us and further your learning process. So I chose the PhD. And I'll tell you just a little bit quickly about the VIE project. So it's a feasibility study, which means that we really wanted to have a real picture of what it is to work with this clientele and within the hospital settings as is. So very little exclusion criterias. We had 3 axes. I was part of the physical activity axis with a whole group of searcher, but there's also a nutrition axis and also psychology axis. It was over the period of 4 years. Now the intervention are done, and we are collecting all the data, and we'll be publishing in the following years. We wanted to recruit patients between the 2nd and the 4th week after their diagnosis. We were able to recruit 62 patients, and in the intervention group, they were assessed once a year for 4 years, and we tested physical capacities, their quality of life habits with a questionnaire, so whether they were active on their own at home, and it could be like active transportation, like walk and taking the bus and all that. And we had a control group that were the matching patient or participant of the intervention group, but after their treatment. So they matched in age, in cancer type, the sex, and the treatment protocols, but they didn't have a specific physical activity intervention, so they would just do whatever they would do normally. And they were seen just once, where we tested them with the same aspects. All subjects were recruited for the intervention group were between the age of 2 and 18, and we included all cancer types. So the intervention for the VIE project, basically we worked in a multidisciplinary approach. So we had meetings between the physio, the occupational therapist, it could be the doctors, could be the nurses, but also nutrition and psychology twice a month to talk about, how the patient going, if there was information we could share together to help the progress of the child in the best way possible. But before each session, we would meet with the nurse, and we would see if there was, different criteria with the blood counts and glucose, or is there any new discovery about his health, such as bone mass, or loss of bone mass, or heart problems, anything that we should be aware of. We would ask also the nurse what is the schedule for the day for the child, so that we wouldn't overload the child, but also so that the child wouldn't miss his appointment. We were aiming at doing sessions twice a week, and we would aim to do sessions between 5 and 45 minutes, depending on the child's capacity and also the schedule. We could do the sessions either in the child's room, in a special laboratory that we had, that was physical activity room, that was a few floors down. It could be in the hallway of the hospital, or also with the Zoom platform, especially during COVID. We would have intensities ranging between 50 and 80% of the predicted maximal heart rate capacity that we would measure with a sensor of a Polo watch. So the person supervising the activity would wear the watch, and we would have a small sensor that we would put directly on the child's arm that would secure with a non-adhesive tape. And that way it would allow us to clean easily the device and switch between children no matter their arm size. And we would also test the perceived effort perception, the perceived effort, so that we could also compare the measured effort with the perceived effort, and also test different tools to evaluate intensity. within my PhD, I had to do a systematic review of literature, and this should be published soon. So I had to question, so I chose 7 databases, and I'll show you a little bit of the highlight of what I found, which is basically why I am presenting today. So I gathered 51 articles that were selected, a little bit more than 51 because I'm still adding new articles that were published recently. It includes 1,193 subjects that were younger than 20 years old. And we selected all articles that had physical activity programs that were either in hospital or out, or could be in both settings as well, and either during treatments or up to the maintenance phase. We looked afterwards at the dosage of physical activity versus the effect that they observed. So either the effect were classified as positive, so they gained something compared to the beginning of the program, or it could be neutral, which is they didn't gain, but they didn't lose, which is something to consider with this population, because just maintaining is something that is important for this population. Or was it negative? So did they actually have a negative effect of physical activity? And I was looking at any adverse event that were reported by the researcher groups. So I could see that within the articles that I selected that had physical activity program, that they had recurrent conclusions. So one of them was the safety aspects. No researcher reported major adverse event directly related to physical activity. Also, you could find conclusions that were recurring also about the improvement of physical capacities, functional capacities, and also psychosocial aspects. And this is basically findings that were similar to what we could see within the adult oncology population. So basically, this population is no different than the adult population. And in the adult population, they have already published some guidelines regarding physical activity that they just recently updated. So at this point, there are no guidelines for the young pediatric oncology population. So basically the families and the medical staff don't have simple and easy accessible guidelines where they could help the children have access to the benefits of physical activity. And even though there are centers that are more and more open and interested into implementing physical activity without guidelines, this can be something that is difficult. It also prevents, autonomy. So basically, if the families don't have access to the information, they can't have their own initiative to be active. So eventually I was looking myself for resources to help, manage my life dealing with leukemia, and I found the LLSC and their resources, and I was lucky enough to have a meeting with Pascal Rousseau, who is the community service manager in Quebec, and I eventually shared with her, the findings that I could see within my systematic review, and how it would be nice if we could gather all this information and create the first guidelines to help the families and the hospital have, be able to implement physical activity in a simple and safe manner. So we've been working on that for the past 2 years, and this is what we're presenting to you today. So a quick overview of this population. Nowadays, science have come a long way. Most of the children, so more than 80% of them, all cancer type included, will survive their cancer. which is amazing. Although they have also a very long survival compared to the adult. They have their whole life ahead of them just after their cancer, basically could be 60, 80 years. And 2/3 of them will have at least one chronic health problem that is directly related to cancer and its treatment. And we'll go a little bit into that after. It also has social integration challenges. They are 3 times more likely to be in disability. They are 2 times more likely to lose a job. And they are 50% less active than their healthy peers. And it has been shown that the deconditioning of the youth after cancer is directly related to difficulties in social integration. Some of the long-term effect of treatments could be heart toxicities, pulmonary toxicities, neuropathies, growth delay, reproductive disorders, cognitive impairment, and they are also more at risk of second cancer or relapse. Now, some of the benefits of physical activity: it improves muscle strength, it increases cardiovascular capacities, increases quality of life, mood, decreases the perception of pain, improves functional abilities, maintains body weight, it affects positively mental health, and also, as I said earlier, being physically active, and also, so basically being physically active during treatment helps maintain physical activity after treatments. So regardless of if they had physical activity habits before treatment or not, if they are during treatment, then they are more likely to maintain afterwards. Other benefits that are shown more and more within studies are that physical activity may have a protective effect on the development of long-term comorbidities, such as heart toxicities, loss of bone mass. It could prevent motor skills disorder or metabolic diseases such as diabetes or obesities. If we look at the ratio risk benefits in the literature, so during growth periods, the risk of inactivity is very high. So there are a lot of risk of being inactive, and it affects directly the child's development in the long run. The risk of inactivity impacts the reintegration into life after cancer, as I said before. And there are no adverse events that occur in literature directly related to physical activity during or after treatments. And we can see the benefits reported in literature for the last 20 years. So basically, there are more risk at being inactive than being active. What are the recommendations that we put together with the LLSC? So we could see also in literature that the type of supervision had an impact on the benefits that the child could get from the activity, and also from the participation rate of the child. So whether it was at hospital or at home, supervised activities had greater benefits and a greater participation rate. So this is something to consider for hospitals, to have someone that is supervising the activity, or for the parents at home to supervise their children during the activity. So some things to consider for safety: before being physically active, before starting physical activity, it's important to see with the doctor if there are any limitation that the child may have that we should adapt the session to. Choose a space always where there won't be any object or obstacle where the child could trip or hit. So make sure that the space is safe. Also, if you are at hospital and the child has an infusion pole, consider being two person to supervise the activity, one who is following the child with the pole. And you could also do a loop with the tubing behind the child's back that you can tape directly on its clothes, so that if the child go faster or if the child trips or anything like that, then it won't be the catheter that flies off, but really just the tubing that rips off the child's clothes. So that would be a safe approach. So there are a few things that we can adapt the session of physical activity to, but there are also things that we would basically postpone the activity. These are things that we don't adapt the session to. So if the child has a fever, where was vomiting or is vomiting, has diarrhea, as an infection, as difficulty breathing, as an abnormal heart rate, then we reschedule the activity. The following things are aspect where we can adapt the session to those variables. So basically, if the child has low platelet levels, it could be more at risk of, say, having bruises or hemorrhages. So you want to avoid the child from falling, or you want to avoid the child to have to catch object. So you can choose instead to play on the ground directly, or in the bed, or on place. So basically standing, or you could do like hoops, basketball hoops and such like that. And just make sure to roll any object slowly towards the child so it doesn't hit him or her. And stay nearby always during the activity so that the child doesn't fall, or if he loses balance, then you can help the child. If the child has low neutrophil level, then he could be, or she could be, more at risk of infection. You could choose to avoid anything that is made of cloth or paper or cardboard, because you really want to wash the object before, and also because they can harbor some bacteria. Wash also the child's hand after the session, and favor always plastic toys. That would be best. If the child has low hemoglobin level, then the child could, depending on the level, could be very, very tired. So depending if the child is awaiting, say, a transfusion, then it may be best to wait after the transfusion. But otherwise, do an activity that is very low intensity. And avoid all activity where the child has to bend over to get, say, an object on the floor, or anything where the child could hold its breath, say during, like if you say weight lifting with teenagers or stuff like that. So you really want to do something that is low energy, but also, like, say, if the child drops something on the floor, you may help the child by picking the object for them. You can favor activities that are seated, or have the child just standing instead of moving around. Watch for all signs of fatigue. So if the child is breathing a little bit heavier, the color of the face, or if the child is sweating or anything like that, allow for as many rest periods as possible or as needed. If the child has low blood sugar, say because they're doing a blood test or any type of test, you can do very, very low intensity activity, because it can be long periods of time if they are on an empty stomach, or you just simply postpone the activity for after, when the child will have eaten. This is the form that we would have the nurse fill out before every session of physical activity during the VIE project. So as I mentioned, like the ones that are at the top are the ultimate contraindication. So basically we wouldn't do the activity if there's a yes in any of those. The other ones are things that we can adapt the sessions to. We would also see anything related to cachexia. So if the child has lost more than 30% of its body mass since the beginning of treatment, or if they have like other things that we need to know, such as a new discovery for pulmonary toxicity, heart problems, or anything like that. How to be physically active with the oncology patients? Well, any amount is good, as in all amount, like there's no minimum. You could do as little as 1 minute. There's no minimal amount to receive a benefit. There are too much amounts. So this is important to adapt the session to the things that some of the things that I've already covered, but that we'll see a little bit deeper in after. But just being a little bit active is good enough as well. Always take break during the activity to be able to measure and evaluate the intensity for the child. And you can also do short sessions multiple times during the day instead of one session of 1 hour. So below you can see the recommendation of the CSEP divided in different age categories. So these are more like objective for the good development of the child, but they're not obligatory. It's really, you need to be wise about what are the capacities for the child for that day. So on good days, that could be something that is feasible. Otherwise, it could be shorter period of time, and this could be more an objective for another day. Frequency. So the child should be active a few minutes every day if possible. It's important to consider and adapt the session to the child's ability and mood. So if we compare to a healthy population and we do training, usually we would see a linear progression every day or every week or a long period of time. But with the children that are going through treatment, it won't be linear. It will really be like ups and down. So one day could be a good day, and then the day after could be a difficult day. And we can't increase as we would with a healthy population. So what we want is for the child to feel that the ability that he or she have on that day is enough. So what can he or she do well on that day? What is gonna make them feel like they achieved something within their ability? We don't want them necessarily to compare themselves to before their disease or yesterday or their friends' capacities. We really want to focus on what they can do on that day, because it's hard. They're already going through a very difficult period of time, and we want to underline and celebrate what they're capable of doing. And also about the mood, they're going through a lot of things on that level as well. And one of the things that is difficult for most of them, if not all, is that they have very little occasion to choose things. So to choose treatments, to choose samplings, to choose where they sleep, what they're going to eat, and all that. So they are forced to do things a lot. Like as adults, we can choose to get treatment, but as a child, they are forced to. So this can be very difficult and frustrating for them. So what I've learned within my training in France, and what I want to share for everyone, is the physical activity should be within the choice category. So the child has the choice either to even do the session, but also to choose whatever he or she wants to do, and so that he in that period of time can have that freedom and can be heard. That helps to build a trust relationship with them as well, and to build a retention for further other session in the future. And also for anyone really, even sick or healthy, pushing and forcing often leads to giving up. So you want to go with them. So this is a tool to measure intensity that you can use. It's the Borg rating scale. It can be used with older than 10 years old. You can try it with younger children, but it's harder to evaluate your own exertion, on fatigue when you're young. And even if you're older, something to keep in mind, even with teenagers, is sometimes it's hard for them to self-evaluate or to be honest about their fatigue, their exertion, because first of all, they don't have the same capacities as before, and they don't necessarily want you to know. So it's important to be aware of certain signs, but you can do the intensity between moderate, which could be like, say, number 4 on the scale, or up to number 7, and be really within a good amount of activation. And there's no harm in being more intense. It's just those periods are shorter and less frequent, as it is said over here. So other tools to monitor intensity could be the breathing of the child. So is he capable of talking within the session? If so, then it's considered to be a moderate intensity. If the child has hard time keeping up a conversation or just talking, then it's higher intensity. You could also relate to the face of the child. So is he red? Is he white? Is he sweating? These are also good signs to tell if it's too intense. So you can allow for short periods of rest at that time, and allow for the child to return to a more moderate intensity. As I said, high intensity is good, but there are shorter periods of time and they are less frequent. So you could do them a couple times a week and they would last, say, for a couple seconds. Then also, when you choose the activity, you want to go with the interest of the child. Really, as I said earlier, you want them to choose. So you can, of course, talk with the child and see what the child is into. What are his or her goals in general? It could be, for younger kid, it could be just to escape from the hospital in their mind and go into an imaginary world. Or for older children, it could be more about their appearance, their capacities, and because they can be more self-conscious about how they look. So you could have, they may want to gain muscle mass or gain weight or lose weight or whatever their goal. But you also have, as someone who supervised the activity, what is the goal for the day, for the session, because you want the child to achieve within their ability for that session. So you could keep in mind also shorter goals for the session. And it could be, say, oriented on the Frozen theme, on the Avenger, or it could be about a sports, and really build the activity around their capacity. So some case studies now. These are based on what we did in the VIE project. So for a day clinic, if the child was coming in, say, for a blood sample for results or a test or anything, then we would go and see the child, see how he's doing, if he's into moving a little bit with us today, and if he is, then we'll go see his nurse and ask if there's any contraindication, what is the blood formula results for today, etc. Are there other appointments? When are they? And to make sure to not overwhelm the child, but also so that he doesn't miss his appointment. We'll indicate the nurse where we'll be with the child, with the phone number to reach us in need. And we'll say, an approximate duration of the activity or the time where we should be back. Then we would really build the activity around the capacity of the child for that day again. And if possible, we would include the family and friends. These are really good opportunities for the family to see what the child can do. So they haven't seen, for most of them, the child being active and being, fully who they are since the diagnosis. So you really want to include them, show how to supervise, within the activity, without really saying this is how you supervise, but just showing by example And often we had families who came back to us and said, oh, we bought, her boxing gloves and a punching bag because we saw how much she liked it. Or, we bought those tools to do, like adventure path, within the house or whatever, or they started being active. So just showing how and what the child can do can really help the family be autonomous at home. During hospital stay without isolation, so the child is usually able to get out of his room, we would first start by seeing the nurse, of course, and seeing how the last 24 hours went. Is there anything that we should know? What is scheduled for the day? Is there school? Is there physiotherapy? How should we manage our session so that the child has enough energy to do everything? And also when to see the child best. See if the child wants and how he's doing directly in his room, talk to him or her, see if he wants to leave the room, if that's possible. Otherwise, we would do the session directly in the room with him or her. And as we speak with them, we would evaluate also what they tell us about how they're feeling, what they did, say, since the last time we saw them, but also how are they moving? And this is how we evaluate the capacities for the day. Like, are they capable of, are they really active, already off of their bed, or are they in bed and really like tired and whatever? And then this is how we would slowly tailor the activity to the child's capacity. Again, we can include the family, or often they would take this opportunity to take some rest, either take a quick shower, go for a massage or things like that, so that they can, take this valuable time for themselves as well. If the child is in isolation, then again, we would check with the nurse as usual. We would follow all the entry-exit procedure for, depending on the isolation situation, clean the equipment if needed. Also, all the equipment were cleaned between each child. Then we would talk to the child, see what the child wants to do. Of course, he's not allowed to get out of his room. So, either they are at risk of infection or either they are infected. So we want to make sure all the equipment are adapted to that as well. And if the child has energy, we would customize a session in regards to his mobility and the space that we have in the room. And if the child is, well enough, you could be surprised at how intense a session could be, even by staying in a very small area. So we could really tailor to the space. And of course, always watch for sign of fatigue, especially if the child is battling an infection, depending on, the degree of infection, of course. If it's really intense, as I said earlier, we wouldn't do a session. And either include the family or allow for a nice break. In transplant situation where the child is having a hematopoietic cell transplant, then we would check the child's condition with the nurse, see how it's been doing. And for those children, we would really take more time to do some chatting and spending time with them, because they are really isolated for long periods of times, and we want to build a relation with them. And often, since they're there a lot, we will see them more frequently. So we want to make sure that there's that we adapt to them, but also that we build a nice relationship with them, so that we can have a good participation with them. We'll assess, as with any other child, their capacities and ability for the day, and see really what he wants or she wants to do for that day, what would make him or her happy for that day. And if it's possible, then get out of the bed. And sometimes they have, mats on the floor that we can use to do physical activity on. Sometimes you can have a bicycle in the room, and this is really helpful for different hospitals if you're considering it. Most of them would start having some or have some already, because they can really lose a lot of weight. At the end of life, so palliative care, phases of treatments, it is really beneficial for them to be active, and not for the same reason. Of course, we're not looking into gaining muscle mass and capacities, but really allowing the child to be a child, to have fun, play, see what he's capable of doing, allowing also for the family to see what his kid is able to do and how he's able to be a kid still, and take advantage of all the time that he has. So before seeing the family, we would see with the healthcare team if the family wishes to be met by our team, and are there any information regarding the wishes of the family that we should be made aware of, such as is the child aware of the end of his life coming closer, or of the situation in general, so that we won't interfere in a negative way, but really go within the family's wishes. As with any other child, we would go with the child's interests and abilities and customize to, the wishes and ability for the day. As nurses, but also as anyone who works within the health field, how to support physical activity? Well, basically just being aware of the risk of inactivity and the benefits of activity. Keep in mind that they need to be active. It's more dangerous for them to be inactive. It is safe to do physical activity, but also now certain aspects that you can keep in mind to make sure that it will be done within a nice frame that is optimal for them. You can also encourage the family's initiative to be active, and also keep in mind what are the recommendations for the doctor, or refer them to the doctor so that the doctor can really make sure that the child is staying within the recommendation and being safe always. You can also refer to the LLSC resources that we've created, that are the guidelines pamphlet that are available, or you can also refer to resources within your hospital if there are some available. Working in teams always helps, as we did in the VIE project, working with a multidisciplinary team together. We were able to accompany the children, being aware of all the different aspects of their healing journey, and all obstacle or difficulty they may go through. Really helps to reach a common goal, which is that we want the child to go back to his normal life, or the life after cancer, the most smoothly, the most in the most natural and normal way, so that it won't be too hard for them, and that they can reintegrate life after cancer. So quickly, what is the role of kinesiologists who have training in pediatric oncology? So we aim at activating the whole body. As physiotherapists or occupational therapists may focus more on acute situations, such as learning to walk again, learning to brush your teeth or to write, and things like that. We really want to, at the same time as the child is learning back to work again, we want to make sure that the rest of the body is healthy and strong, and that all the other aspects of his body are being maintained or increased, because we want to facilitate again the return after cancer. To wrap up, in conclusion, so children with cancer need to be active during and after treatment. Physical activity is safe as long as we follow some important guidelines that should be considered. Families can be self-sufficient and autonomous within physical activity, especially if they have those guidelines. And having a trained professional to supervise a session can increase the benefits and participation, which is something to consider for hospitals to have a trained professional to supervise intervention. These are the pamphlets that we've created. Those are specific for children during cancer treatments. So they are divided in different age groups. We made one for physical education teachers who have children who are survivors of cancer. And we also made one that is for survivors, so the kids who are, you know, going back to a normal life after cancer, to help them in that transition. So there aren't many resources, unfortunately, at this time, but we did do those pamphlets that are available to you either on the website of the LLSC, or you can also order them. We have, it's kind of cardboard fact sheet that you can have and distribute within your hospital. I'm also glad to offer any monitoring through the LLSC on request. And I'll be happy to meet you within your hospital, to meet your team and evaluate your needs and see if there's anything I could bring to help you implement physical activity within your walls. So those are some of the resources that I've based my research on. These are also good reads if you want to learn a little bit more about PAPO. And I want to thank you all very much, and see you again, maybe.
Thank you, Gabrielle, for this very interesting presentation. And to those of you who have joined us today, I hope you enjoyed it. As our expert mentioned, she is available to answer your questions about exercise and pediatric oncology. After viewing this training, you will have the opportunity to leave your name and questions on a form designed for this purpose. Gabrielle will communicate and follow up with you directly. I would like to remind everyone that we are here for you. Do not hesitate to contact the LSC if you need any more information. You can reach us by email at info@bloodcancers.ca or toll free at 1-833-222-4884. Also, make sure to check our website regularly at bloodcancers.ca. Thank you and stay safe. Have a nice day, everyone.